Thank you. I want to thank the organizers for inviting me here today. As Ray said, I am Ty Dickerson. I'm a pediatric hospitalist here at the University of Utah. I'm also have an appointment in the Division of Public Health here, where I do most of my global health work. Today I'm here to talk to you about improving maternal, neonatal, and child health in low-resource settings. I'm happy to report. First, we'll go through some learning objectives. We're going to talk quickly about some epidemiologic trends in child maternal survival, identify some specific populations at risk for high mortality, identify the main causes of mortality in these groups, and then discuss some novel approaches to improve survival among rural and poor women, neonates, and children in low-resource settings. And finally, we're going to talk about how the approach to improving maternal and newborn survival is going to need to be quite different from that of improving child survival. So I'm happy to stand here today and say that improvements in child survival globally in the last 2 to 4 decades has been an unmitigated success. When I first started working in global health about 13 to 15 years ago, the estimates for under 5 mortality globally was about 15 million kids not making it to their 5th birthday every year. More recently, that number, our best estimate, is about 7.7 million children across the globe under the age of 5 die every year. And as we can see from the graph here, could we go back? Am I moving this slide? Or as we can see here, this is under 5 mortality. The bars to your left represent mortality in 2008 and in 1990. And we can see at the top the sub-Sahara, about 184 deaths per 1,000 live births. 18 years later, that number is closer to 140. We see for all the WHO regions that child survival has improved, in some places dramatically. We see over on the right that we still have some problem areas. Those nations represented in the red are not on track to meet the Millennium Development Goal number 4, that is decreasing child mortality by 2/3 by 2015. And those in the yellow are making insufficient progress. We see that is concentrated largely in sub-Saharan Africa and South Asia. However, looking just at regional or country-specific mortality rates misses a large part of the picture, and that's what I'd hope to impress upon you today. Across all regions, and these are developing regions, under 5 mortality is much higher in rural areas. In developing countries, we see that your chance of dying before reaching your 5th birthday is about 1.5 times higher if you live in a rural area versus those children that live in urban areas. Similarly, the poorest households suffer the greatest burden of mortality as well. In developing countries, you see that a child that lives in the lowest quintile by wealth is about 2.2 times more likely to die before the 5th birthday than a child that lives in the upper 20th percent. I think this is profoundly important. If we are going to see further gains in child survival, we must reach these poor and rural populations. Next slide, please. Similarly, for maternal mortality, this is data from China alone, from about, let's see here, I'm having trouble, this 1996 to 2006. And this data is similar in a lot of regions in the world. We see on the far left maternal mortality in urban areas, and we see that there's been a moderate decline in maternal mortality from 1996 on. However, looking at the next 4 domains, these are rural areas, and you can think of rural area 1 on the screen as eastern rural, near some of the large population areas, and then on the far right, rural area number 4 as being the far west, the poorest and most rural parts of China, including large proportions of the Tibetan Plateau. And we see that although maternal mortality has declined significantly, it clearly is most problematic in the rural areas. Next slide. Similarly to children, for women, income and access to maternal health services are highly correlated with wealth. We see the sub-Sahara on the far left, developing countries in the far right, in the green, and we see that a woman who lives in the lowest quintile by wealth is far less likely to deliver her baby in the presence of a skilled birth attendant. That is a nurse, doctor, or midwife who has the skills, knowledge, and resources to manage a normal pregnancy, labor, and delivery. And we see that poor women are far more likely to deliver in the absence of a skilled birth attendant. So child health and maternal health, poor outcomes, highly correlated with rural dwelling and low income. Next slide, please. So this data and much other data suggests that further improvements in maternal and child survival will require a focus on poor and rural populations if we're going to see further gain. This clicker is just not working for me. So how can health systems respond to this need? Next slide. So first I'd like to present a fact. Most maternal and neonatal deaths occur during or shortly after birth. Next figure. So 25 to 45% of all neonatal deaths you'll see occur in the first day of life. And you'll see 75 to nearly 80% of neonatal deaths, about 3 million per year worldwide, occur in the first 48 hours of life. Next. We see that more than 50% of maternal deaths, and that is a death due to in a pregnant woman due to that pregnancy. Half of those deaths occur in the first 24 hours of life. Another 25% or so occur 24 to 48 hours. The first day postpartum. And what this tells us is that to improve neonatal and maternal survival, we have to get to these women and these neonates. We as medical providers, need to make sure that we reach them during this very, very crucial, relatively short window of time. Next slide. Since most maternal and neonatal deaths occur during the intrapartum and postpartum period, clinicians and health services need to respond quickly and consistently, 24 hours a day, 7 days a week. Next. But before we think about how we might solve this problem, we have to know, what sort of resources and skills are necessary to address these deaths, and we have to know about what is causing some of these deaths. Next. Next. So we see here on the right a pie chart that breaks down under 5 mortality by age, and we see that about 40% of all under 5 deaths occur in the neonatal period. Neonatal period represents about 1.5% of early childhood, up to 5 years, but we see that over 40% of the deaths occur there. 2/3 of these deaths are due to 3 conditions primarily: complications of low birth weight and prematurity, asphyxia right around the intrapartum period, and severe infections. Next slide. Similarly, about 80% of maternal deaths are caused by just 5 direct causes: severe bleeding or postpartum hemorrhage, severe infections, hypertensive disorders of pregnancy, unsafe abortion, and obstructed labor. I think it's extremely important that we focus on these causes of death in these 2 age groups, simply because unlike improving child survival, improving maternal and neonatal survival is not something that is immediately amenable to low-tech, low-resources, low-skilled, community-based interventions. Very, very difficult to manage postpartum hemorrhage in the field without expertise, without resources, without a functioning facility. Same for complications of prematurity, severe infections in women and neonates, birth asphyxia. So the causes of these deaths is informative. Next. To address these deaths, we need universal coverage with skilled birth attendants everywhere, 24/7. I know, a tall order, but we're simply not going to decrease deaths due to postpartum hemorrhage without skills, resources when they are needed. We need to improve referral systems to higher levels of care. That will include communication tools and improve transport. We need a reliable chain of supply and resources and functional facilities. And I think some of the ideas, innovative, extremely affordable ideas that are coming out today may be able to address some of these issues. Next slide. So UNICEF has developed what they call an equity-focused approach model to maternal child health. And the goal, recognizing that many of these deaths are concentrated in the rural poor, is to meet the health needs of these populations. They recommend upgrading selected health facilities with a focus on maternal and newborn health, expanding coverage of birthing or maternity homes, we'll talk about in a second, and making sure that referral facilities all have emergency obstetric and newborn care signal functions, and we'll talk about those signal functions in a minute. We need to overcome resistance to using health systems, including expanding outreach services. And I think that outreach services are a great way to improve under 5 survival. Elimination of user fees and other costs, as well as harnessing mass communication technology. We also have to promote task shifting. It isn't the MD that needs to be taking care of all these clinical issues. I think that there is, especially in child survival, there's a great opportunity to use community health workers to deliver some of these basic healthcare services. Next slide. Some folks have kindly done us a favor. WHO has promulgated comprehensive, essential emergency obstetric functions for a long time. And some colleagues have also added newborn care signal functions to that list. They're listed here, but I think I have a better slide next. So signal functions on neonatal care first. What is needed in these referral centers to improve neonatal outcomes? Well, in community and clinics, next, we need, about 136 million babies born every year, you see on the pyramid to the right, will require only basic newborn care or newborn resuscitation, if you will. Thermal protection or keeping them warm, either skin-to-skin care or kangaroo care, or whatever you want to call that for these neonates. Immediate initiation of breastfeeding to combat hypoglycemia and hypothermia. And infection prevention, such as allowing the cord to dry, not putting harmful substances on that umbilicus. 136 babies all babies will need these maneuvers. Next. A fewer number, approximately 10 million babies, will be born with respiratory depression and will need just simple drying and stimulation that can be life-saving. Next. A smaller number, a few million, will need positive pressure ventilation. And these are probably the babies, some of those 3 million babies, about 1 million a year that are dying from birth asphyxia. Something so simple as an ambu bag or some mouth-to-mouth resuscitation could lead to recovery of these depressed newborns and could be life-saving. Interestingly, next, the referral centers would only capture a small number of the 150 or so million births every year and would need these signal functions. Injectable antibiotics, difficult to do in the field but possible. Intravenous fluids, oxygen, antibiotics for premature rupture of membranes, and on and on. Next. So there has been a strategy called the Intrapartum Care Strategy. Those of you who are familiar with the Lancet Maternal Survival series by Ronsman, I believe in 2005, has recommended this approach. Next. So in homes and communities and clinics, literally everywhere, there needs to be a skilled birth attendant, such as a midwife, doctor, and nurse, available 24/7 for labor and delivery. These people need the skills to manage normal pregnancy and childbirth, and they must be able to recognize and refer for complications. However, if you think back to the slide, postpartum hemorrhage, eclampsia, obstructed labor. These things are very, very difficult to manage in the community setting. So if we're going to make further gains in maternal survival next, we need referral centers that have a very close relationship to the communities and clinics to deal with these 5 leading causes of maternal death next. These referral centers must be able to deliver these obstetric care signal functions, tocolytics such as oxytocin, the ability to provide blood transfusion for severe hemorrhage, surgical delivery or cesarean section for obstetric labor, postpartum hemorrhage, and on down the list. We simply cannot do without these services, and they must be available at the time they are needed in that 1 to 2 days around the intrapartum period. And this has been termed the intrapartum healthcare strategy for maternal and neonatal survival. Have the basics in every community available 24/7 with a strong referral system to a facility that has these signal functions next. So how might that be done? Well, in Haiti and elsewhere, the concept of a birthing home has been successful. Recognizing that a majority of these deaths occur at home, recognizing that these life-threatening complications are very difficult to manage at home, the idea has been to build a socially and culturally acceptable birthing center staffed with skilled birth attendants that can manage the great majority of uncomplicated vaginal deliveries. Women come here, they can bring their own food, they can stay. It's similar to home, not the sterile environment in a district hospital where there are often costs that they can't afford, they're often treated poorly, and is a very, very foreign environment. Next. So the Haitian birthing home resembled local homes. There were no user fees. They provided quality care with trained nurse midwives or SBAs, and their performance was monitored. Neonatal mortality decreased by 50% versus the control group, where most of the women delivered at home rather than the birthing center. Next. The approach to children under the age of 5, next, is going to require a very different approach. We see that majority of, or 40% of under 5 deaths occur in the neonatal period, some of those due to infections. But the vast majority of kids from 30 days to 5 years die from complications of our old nemesis infections: pneumonia, diarrhea, malaria, measles, AIDS, next. And about half of those infectious deaths are due to undernutrition. If we could eradicate undernutrition, we think that we could decrease global under 5 mortality by about 50% immediately if that were possible. These are what I like to call slow deaths, not that malaria can't kill you quickly, but unlike postpartum hemorrhage, there's the mosquito bite, the inoculation, there's a period of time, the child usually is febrile, becomes sick, and these deaths occur over many days in general, although there are exceptions. Next. This is very different than managing birth asphyxia. You need to be there immediately. Managing postpartum hemorrhage, you need to be there. You need very skilled providers. You need good resources and good facilities. My last 2 slides here promulgate the community case management approach to child survival. This has been promulgated by UNICEF, WHO, USAID has been heavily involved, but it's premised on the fact that pneumonia, diarrhea, malaria, and malnutrition are the most prevalent killers of kids under 5. Infections requiring antibiotic treatment at home or requiring referral care can be recognized using very simple clinical signs. We can bring curative care to these rural communities. And I'll show you how next. So the community case management approach addresses common causes of mortality in kids 2 to 59 months of age, uses 4 low-cost medicines and 2 simple tests next. An antibiotic, usually amoxicillin for pneumonia, next. An anti-malarial drug, and keep going here. Oral rehydration solution with zinc tablets, which has been shown to improve outcomes in diarrheal diseases, as well as rehydration. The recently available, very affordable malaria rapid diagnostic test that can be used in the fields, and also what we call a MUAC strip. Simply a strip you can wrap around the upper middle arm to determine the degree of malnutrition of a child. So very, very simple and very few resources. For those that are interested, the manual for the community health worker there on the right-hand side of the, or left-hand side of the slide is very, very informative. Next. So how does this case management process work? Community health worker assesses for 12 major danger signs, and they're very simple. No counting pulse, no checking perfusion. If any of these danger signs are present, these children are immediately referred. If there are no danger signs, they look at main symptoms, nutritional status, immunization status. Next. They then classify these children as needing referral, specific treatment or home, or symptomatic management at home. Next. They identify and treat these 5 major conditions. Next. And then they counsel the caretakers and they follow up. Next. So it's very simple. To finish, 3 pages from the 12-page guide for these community health workers. At the top, you see the major danger signs: cough for 21 days, chest indrawing or respiratory retractions. Any of those signs is immediate treatment and referral. You see in the red boxes, we explicitly tell the community health worker how to begin treatment. Diarrhea, ORS. If fever, an anti-malarial drug, and we have a lot of great ones now, thankfully. If fever and cough, chest indrawing or fast breathing, amoxicillin, 2 doses a day for 3 days, has been proven to be equivalent to 5 days or longer. So 6 amoxicillin tablets, very cheap, relatively high compliance with that short schedule, and can be life-saving. Next. If there are no danger signs and no referral is necessary, very explicit instructions. In the event of fever, do a malaria rapid diagnostic test. No more empiric therapy with antimalarials, raising resistance to these drugs, as we've done with chloroquine, sulfamethoxazole, or Fansidar. And then finally, checking for malnutrition and referral to the clinic. Next. So in conclusion, maternal and child survival has improved dramatically in most regions of the world. Populations at greatest risk are increasingly poor and rural. We must reach them if we are going to improve maternal, neonatal, and child survival. Further improving survival will require bringing skilled providers with advanced resources, functional facilities, and efficient referral capabilities to poor and rural areas. For children, a little bit different. The major killers are amenable to identification, recognition in the community setting, and treatment in that setting. Thank you very much.